ulcerative colitis, which is risk averse, will be ustekinumab. Crohn's disease, patient is risk averse, go for ustekinumab. Patient has a severe disease, go for infliximab or adalimumab with azathioprine, or you can go for ustekinumab monotherapy. And I think that is with this, I would end my presentation. Thank you so much.
Vineet, I think you have, as Dr. Sandeep said, a huge number of questions. So I was just trying to club them up. So I think in India, cost is a major issue. So there are n number of questions on tofacitinib.
Ustekinumab, and subsequently when Rasanik is really help as compared to conventional management when it comes to TNF antagonists in IBD. There was no benefit in clinical remission at 1 year if you did proactive therapeutic drug monitoring. So as of now, unless there are very special cases like fistulizing disease, acute severe ulcerative colitis, you would not like to do proactive drug monitoring. So this is the table which we have built till now. We have talked about PNR to anti-TNF. We have talked about prior response to infliximab, that is loss of response. What happens in patients with ulcerative colitis when they have been given vedolizumab as a first-line therapy and there is a failure of vedolizumab? What do you do? There, the possibilities that you are tofacitinib, infliximab, ustekinumab, and surgery. What about acute severe ulcerative colitis? No response to IV steroids. All these agents are available. And obviously, there are patients who can afford, that is tofacitinib and surgery, and there are patients who can afford these kind of agents. What do? You find that you can use infliximab, you can use cyclosporin, surgery, or tofacitinib. You would not like to use adalimumab, you would not like to use vedolizumab, you would not like to use ustekinumab, simply because, as I told you, the half-lives are 25 days, 19 days. So obviously, the rapidity of response would not be there. Here, half-life is 8 hours. The rapidity of response would be there. But tofacitinib, whenever you're giving, the dose is 10 milligram 3 times a day for 3 days. And thereafter, you give the regular induction dose, 10 milligram twice a day for 2 months. And you always give thromboprophylaxis in this situation. Now comes an interesting point. Can you increase the dose of infliximab and would it help?
Dr. Vineet, we need to take a break when you want to have it.
5 minutes and then I take a break, 5 minutes or something.
Okay.
So, can you increase the dose of infliximab? Would it help in acute severe ulcerative colitis? Because there's so much of inflammation going on. So there are 3 kinds of regimes which have been proposed. Either give accelerated dose of infliximab, 5 milligram per kg at week 0, 1, and 3. Other is higher dose infliximab. Give 10 milligrams per kg. Many centers do that. 10 milligrams per kg at week 0 and week 1. Or you give the standard dose of infliximab, 5 milligram per kg at week 2, 0, and 2. Which is the best among them? Right now, this question is sub judice. In other words, a very nice study which is going on, and that will only tell us the results. Otherwise, whatever evidence is available is not able to clearly decide whether accelerated dosing of infliximab or higher dose of infliximab is useful. So any one of these you can use right now till we have a definite evidence. Finally is elderly safety, where safety is a predominant thing. There is absolutely no doubt about that vedolizumab and ustekinumab are the preferred drug therapies. What about pouchitis, chronic refractory pouchitis? Which biological would you like to give? In very recent NEJM paper, which showed that vedolizumab had a 3 times higher response compared to placebo, makes vedolizumab as a drug of choice for chronic refractory pouchitis because you have the best data available for that in this kind of setting, a randomized controlled trial followed by infliximab. Tofacitinib can definitely be also used. What about extraintestinal manifestations? Infliximab, adalimumab, tofacitinib, ustekinumab, all of them can be used. What cannot be used? Vedolizumab. Because it has been seen that there's a temporary increased risk for developing arthralgias, which has been observed with vedolizumab. Probably the lymphocytes which are wanting to go to the site of inflammation did not reach there. They went somewhere else. They went to joints or somewhere and caused the inflammation. Pregnancy, we had excellent data for infliximab and adalimumab, and now we have data which is emerging for vedolizumab and ustekinumab. And this systematic review shows that adverse pregnancy outcomes in all patients, pregnancy patients with IBD, was comparable to the general population, irrespective of whether it was given first trimester, second trimester, third trimester. You can give the biologicals up to third trimester. So this is the positioning of therapies for ulcerative colitis, where I have marked in orange is something which can be, any one of them can be used as a first line therapy. So these are the various situations, and depending upon the situations, there are a little bit of changes which you would do. What about Crohn's disease? Again, if you make the chessboard, you find there's a little bit of change out here. Adalimumab jumps up from the last position to almost equivalent position to infliximab. B1 Crohn's disease, induction, maintenance. B2, B3 Crohn's disease, infliximab, adalimumab. Fishalizing Crohn's disease, infliximab, adalimumab. What it does is it replaces Vido. It takes over Vido's position, it jumps up, and Vido goes a little bit back. Inflixi, Ada, ustekinumab, Vido, that remains the sequence, in the sense that you would try to use these agents which are much more efficacious. If there's a non-response to anti-TNF, you would like to use ustekinumab or vedolizumab. If there has been a loss of response to infliximab, then you can use adalimumab, ustekinumab, vedolizumab. If you have used Vido as the first-line therapy, then infliximab, adalimumab, or ustekinumab can be used. Again, for patients who are elderly or safety signal is very important, ustekinumab and vedolizumab remain the drug of choice. Post-operative recurrence, best data is for infliximab and adalimumab. Extraintestinal manifestations, again, vedolizumab would be out, and rest of the three agents are there. Pregnancy, any four of them can be used, right? So if you were to position the therapies, you can also do it in another way. That is, one is look at treatment-related complications. Are they more important? Prior history of serious infection, prior malignancy, advanced stage, multiple comorbidities. Look at all the other factors, risk of disease-related complication. If the patient has a very high inflammatory burden, high structural damage, significant impact on quality of life, that is a major thing which is plaguing the patient. So the patient plays a very important role out here. Is he risk averse, or he is more concerned about his disease? If he is more concerned about the disease, the therapy would be different. If he is risk averse, the therapy would be different. In ulcerative colitis, the first line therapy, if it's a severe disease, would be infliximab combined with azathioprine. Thereafter, vedolizumab. Tofacitinib, if the patient cannot afford, would be the first line therapy. Ustekinumab can also be the first line therapy. Any one of them can be the first line therapy. Second line therapy would be ustekinumab or tofacitinib. Upadacitinib should be available in India in 6 months or something. Then obviously it will go to the number one places. What about patients who are risk averse? Their Vido becomes the first line therapy. Ustekinumab becomes the first line therapy. It scores over infliximab or tofacitinib. Second line therapy remains ustekinumab or ozanimab. What about Crohn's disease? If the patient is very concerned about the disease, straight away go for infliximab or adalimumab combined with azathioprine, or go for ustekinumab if the patient can also afford a higher, more costly drug. Second line drug would remain ustekinumab, and subsequently when risankizumab and upadacitinib is available, it can be used. If the patient is very risk averse, then the first line therapy for Crohn's would be ustekinumab. Then thereafter, you can use vedolizumab. Why? Because ustekinumab has a higher efficacy compared to vedolizumab in Crohn's disease, whereas in ulcerative colitis, the data for Vido is good, very good. Second line therapy, you have to go back to infliximab and adalimumab. So essentially what we're doing, I'm very fond of showing this picture. I've shown it earlier, so pardon me if I'm showing it again, but then that is actually the truth. IBD is like Ravan, the demon god with 10 heads. All we are doing is beheading one head. That's all. The head comes back. The moment we behead a head, it sprouts back. You give one anti-TNF, patient loses response, move over to vedolizumab, patient loses response, move over to tofacitinib, patient loses response, move over to ustekinumab, patient loses response. IBD doesn't go away. You need to find out what is the cure for that. You need to find out the navel shot. Till the time you don't find out the navel shot, you definitely will not be able to cure. You will only end up sequencing the therapy. I think I'll take a break out here, sir.
I think that's better. We'll take up the questions. Dr. Devendra and Dr. Ruba, please take the question. And also we'll have some poll questions now.
So I think a large number of questions have come up for you, Vineet. So there's no rest for you.
Okay,
So,
should I start? When can salvage therapy be performed after last infliximab dose in ulcerative colitis? Salvage therapy can be, I'll address it later, it can be performed anytime. If there's an indication, emergency indication, do not wait for even a minute. However, if you have a planned indication, then you can wait for 10 to 15 days. Otherwise, do not wait for a minute. Any role of adding allopurinol? No. Allopurinol you add to azathioprine. When you are giving azathioprine as a monotherapy, and there if azathioprine is not acting, there you can give allopurinol 100 milligrams and decrease the dose of azathioprine to 25 milligrams, and it has been shown to be very effective. ADA in loss of response to infliximab. Yes, I told you two scenarios, primary non-response and secondary loss of response. Please don't have a knee-jerk response. Given infliximab, no response, you can never give adalimumab. You can. If it was a secondary loss of response. If it is a primary non-response, that is, you have started infliximab, induction dosing, no benefit, then no point of giving adalimumab. There you have to go out of class. But if a patient is doing very well on infliximab for 1 year and subsequently loses response, there you can easily switch over to adalimumab. You can do that. Adjunct therapy with infliximab mentioned injection methotrexate. So injection methotrexate, yes, you can give oral methotrexate, but in IBD particularly, IM or subcutaneous methotrexate has shown to be much more efficacious. So one would prefer to give once a week injectable methotrexate. Why doesn't tofacitinib act on Crohn's disease? Because what happens is the tofacitinib blocks the STAT pathway. It blocks the STAT pathways where? More in macrophages. It doesn't block the STAT pathway so well in T cells. In ulcerative colitis, the macrophages are much more important. The innate immune response is much more important. That is why tofacitinib acts. Whereas in Crohn's disease, the STAT pathway in T cells is much more active, which tofacitinib is not able to block so well. That is why tofacitinib and even filgotinib has not been found to be very useful in Crohn's disease. A recent study came out which showed failure of filgotinib, which is another JAK inhibitor in small bowel Crohn's disease. Infliximab versus vedolizumab for Crohn's disease, I think I've shown you very clearly that infliximab is superior to vedolizumab when it comes to Crohn's disease. I'll talk about vedolizumab again. I'll tell you where you can give it as a first-line therapy. Remember, when it comes to inpatients, infliximab would always score over vedolizumab. When it comes to outpatients, you can think when the inflammatory burden is not very high, there vedolizumab may act. It is a slow-acting molecule. It takes time to act. But once it acts, there's a very good retention period. Newer biologicals and IBD, I think, VZ were vaccine mandatory. No, if I showed you in the table, varicella antibody, if positive, do not give vaccine. Herpes zoster antibody positive, still you have to give a vaccine. That is the classical difference between the two. Varicella, if there's history of varicella available, if the varicella serology is positive, don't give varicella vaccine. Herpes zoster, amazingly, CDC says that even if the patient has had, you have to give. Neurobiologicals and IBD, that is P19, IL-23 inhibitors, which I've shown you. That is something which are the neurobiologicals. Of them, risankizumab has already been approved for Crohn's disease. Surprisingly, mirikizumab sent the data to FDA just this month or last month or something, but it has not been approved as yet. Even though Tofa has a pan-JAK effect compared to UPA, why is the response limited in CD? Because it does not act on the STAT pathway in T cells as much as it acts on the STAT pathway in macrophages. So it is not effective. 30-year-old male left-sided Crohn's colitis with complicated perianal fistula, newly diagnosed MRI showed abscess collection. Currently, I kindly advise on the right time to. So first of all, treat infection. Perianal fistulizing disease, unless until you treat infection, you should never treat inflammation. How do you treat infection? You drain the abscess. Put a ceton thread. It's a complex perianal fistula. Give antibiotics. Once you have done these three, then you start biologicals and always add the best biological in this setting is infliximab or adalimumab, and you would like to add azathioprine. So put ceton, drain the abscess, give antibiotics. You are sure patient has started doing well, add biologicals then. Once you're sure that there is no infection. Tofacitinib role in biological experienced patient, excellent experience of tofacitinib in bio-exposed patients. As I showed you in ulcerative colitis, the data show that tofacitinib or ustekinumab perform the best if patients have had a biological failure compared to other drugs. If patient has had an anti-TNF failure, vedolizumab will not perform so well, whereas tofacitinib and ustekinumab will perform very well. Is Entyvio effective for small bowel? Yes, it is effective for small bowel Crohn's disease, but again, if the inflammatory burden is very high, there may be an issue. Are infliximab drug levels and antibody levels useful in assessing the biosimilars as well? Excellent question. I do not know the answer to this one because this is something which has never been properly studied, because what happens is that for the same biosimilar, whether you're going to get the same drug levels or something is a little bit doubtful. Indications of biologicals in UC are showed. Again, tofacitinib is effective in CD. I told you. Where is same question? I've done. I think all patients. Can tofacitinib be used as an induction therapy in subset of patients in ASUC without giving steroid? Again, excellent question. So there's a clinical trial which has been, the one clinical trial has been done, I think, by DMC Ludhiana, Dr. Ajit Sood's group, and another clinical trial is ongoing at AIIMS, whereby tofacitinib has been is being studied as an induction therapy along with steroids in patients with acute severe ulcerative colitis. So without giving steroids, it has not been studied as yet. Just by giving steroids, if I correctly remember the DMC trial. So
we can ask the admin team to put some poll questions, and you can continue with the discussion. Poll questions, please. Meanwhile, it comes, you continue with your discussion.
Yeah, I think Vineet, there is a question also which is coming that what is the role in modern day in India of cyclosporin in acute severe ulcerative colitis now that so many biologics are available?
What the mind does not want to see, the eye will never see, is something. They're saying something like that. So exactly like that. Cyclosporin is very cost effective. It is very efficacious drug. It is easy to give. But at the same time, as gastroenterologists, since we do not give for any other indication, so we are afraid to give it. It is actually an excellent drug, and in fact, in UK, many centers still cyclosporin is used in patients who do not respond to IV steroids, patients of acute severe ulcerative colitis. So cyclosporin is something which requires patronization. If somebody decides to patronize it, it's an excellent drug. The problem with cyclosporin, I'll tell you why people do not use. The second issue is that after 3 months, what do you do? Because after 3 months, you would like to stop cyclosporin. When you stop cyclosporin, you can put the patient on tofacitinib, you can put the patient on vedolizumab, you can put the patient on infliximab. But you would have to move over to any one of those agents, because essentially people feel that, okay, after stopping cyclosporin, you can put the patient back on azathioprine. That has been the pathway which has been thought of. But then these patients have been on azathioprine earlier, and still they got a failure, went into disease activity failure, whereby they went into developed acute severe ulcerative colitis.
Vineet, can we take up this question, please?
Yes, which of these is the fastest acting? Tofa, inflixi, upadacitinib, ustekinumab?
So can you show the response?
We see the answers. Yeah.
So this is the response by the audience.
So the correct answer is number 3, upadacitinib. It has been shown to be as effective as within a day, 24 hours. So it is one of the fastest acting. Next question.
Admin, next. Yeah. Vineet.
This is easy. This is an easy question. Which of these drugs can be used to treat acute severe ulcerative colitis with IV steroid failure? This is just a derivation of the half-lives which are taken.
Anybody who has listened to the talk should be able to get it right, Vineet.
That's an application question. As you give an AIIMS entrance exam, you don't give a direct question, you give an application question.
We go to the answers.
I think,
Show the response.
Excellent. So majority got it right. Upadacitinib is the drug which can be used to. In fact, recent data has come up with case series, again, case reports showing the benefit. Tofacitinib, we have a lot of case series, but amongst these agents, Upa is the one which has case reports which show the benefit.
Next.
Okay. Tofa 10 milligram twice a day given for 8 weeks. Patient moderate to severe ulcerative colitis. Partial response. Patient is not doing well, but not so well. What would you do? You know that giving 10 milligram twice a day is associated with more side events like thromboembolism, herpes zoster. So would you like to still continue it or change over to infliximab, vedolizumab, decrease dose of tofacitinib to 5 milligram twice a day, or add steroids?
Can we see the response?
Depends whether the patient is poor or not. What do you think, Vineet?
Yeah, that is another factor, but still, even if poor or rich, I think the people have got the right answer. That is, you continue induction dosing of 10 milligram for another 8 weeks, because that has been shown to capture response from many number of patients. So you would like to switch over to other agents if in 16 weeks you do not get a response. If the patient had no response at all at 8 weeks, you would have switched, but the patient had a partial response, so you may continue with the same.
Can we now move on to our talk? Vineet, can you share your slides and go to the talk per se now?
Vineet, you can take a sip of water before you start again.
Because my voice is not coming across.
It is coming across, but
There are so many questions.
we understand your job.
Can you share your screen?
Okay, I'll share the screen, sir, and start again. So now, again, best second line therapy after anti-TNF failure. Again, I'm making it clear: ulcerative colitis, tofacitinib or ustekinumab. Tofacitinib is affordable, faster onset of action, but more side effects. Ustekinumab is safe but high cost. Crohn's disease, ustekinumab, we have safety and cost, right? Patient with Crohn's disease had 2 biologic failures. Should you send the patient for surgery or try the third biological? What would you do? This is a situation which many IBD centers frequently see. So there's some very interesting data which looked at 75 Crohn's disease patients who had failed 1 TNF and thereafter given Vido or ustekinumab, and 1 year data was collected. It was seen that if you 25%, 1/4 of them went for surgery, whereas 30%, almost equal number, achieved remission after third biological. So depending upon the situation, you can decide to send the patient for surgery, or you can also try another biological, even if the patient has failed 2 biologicals. What about maximizing the efficacy of vedolizumab? Vedolizumab is an excellent drug, but there are certain situations where it behaves very well. There are certain situations where it does not behave so well. So which are those situations where you would like to use vedolizumab as a first? You can also use it as a first-line biological and extract the maximum benefit out of it. It has been seen that it is more effective in biological naive UC patients rather than anti-TNF failure in UC. In ulcerative colitis patient, if the patient has mild to moderate ulcerative colitis or moderate to severe ulcerative colitis, and the patient has been on anti-TNF earlier, giving vedolizumab after that would half the response. The response would not be that great, as opposed to the situation where if you had started the patient initially on vedolizumab. Secondly, vedolizumab persistence is significantly longer when it is given as a first-line drug. So rule of thumb is used for outpatients rather than inpatients. The effectiveness data is much more strong for ulcerative colitis rather than for Crohn's or fistulizing disease. You will get much more benefits in patients with ulcerative colitis. If there's a loss of response, you may consider adding azathioprine.
Participants, we have participants across India, from outside India, from Malaysia, from Gulf countries. There are so many. And I'm sure this program of ISD Masterclass is gaining real importance and is doing extremely well. And many sessions have, all the sessions you look at, number of participants extremely well. And we have the next session on alcohol-related liver disease, which will happen on September 10th. And I request all the participants to register early enough whenever you get the link, and you can even post your questions at on the day or on day prior to that. So thank you so much, and thank you, Vineet, once again, and thank the moderators once, and especially Dr. Devendra Desai and Dr. Ruba Banji for active participation and moderation. And I would like to thank the admin team for this excellent, arranging excellent platform, and also a silent person, Nisha, who is our secretary in our office work, and she is doing an excellent work. Thank you, and she was coordinating everything. And I thank governing council members of ISC for